Hi everyone, this is Neel Raithatha, consultant audiologist and director of earwax. Thank you for joining me in this very interesting and complex case. It's of a patient who I originally saw back in February early this year, and when they attended, they reported bilateral blocked ears, and they also mentioned to me that they recently had a right-sided ear infection, which was assumed to be otomycosis, so a fungal ear infection, and they had been prescribed Canesten antifungal solution drops. So when I examined the patient's ear, they had the dome of a hearing aid lodged inside. So I'm assuming that occurred after they were diagnosed with the ear infection. But normally with an ear infection, we recommend patients not to wear their hearing aid. So when I removed the dome, and I'm just reading the referral letter that I wrote to an ENT consultant after I initially treated this patient about 6 months ago, there was evidence, according to my letter, of an attic cholesteatoma, and that cholesteatoma was full of wet squams of skin, similar to this, as you're seeing on screen at the moment. They also had some granular myongitis, so it's some granulation tissue on the eardrum, and that was on the inferior part, so the floor of the eardrum around 6 o'clock. And it was quite odorous, their ear, so you could really smell the infection. And when I removed the squams of dead skin in the attic, it was very evident that they've got a cholesteatoma. So I requested an urgent ENT referral, and I think they were seen literally within a week or so, which is great. And they saw an ENT consultant. Now, this patient doesn't live locally, so they travelled to see me from Oxfordshire. So they saw a local ENT consultant who confirmed that the patient has got an attic cholesteatoma, and I'll explain what that is for anyone new to the channel. And they cleaned the ear out as much as possible, but they were against performing any surgery, and that's primarily due to the patient's age. They are soon to turn 95. So the plan of action was just long-term use of topical antibiotics, and they advised to have their ears cleaned, and the consultant was happy for the patient to see myself to have that done every 3 months. So you would have saw at the beginning, the ear was full of discharge, and I've got all these wet squams of skin, so I'm just gently peeling it off the canal wall. You can see at the top some of this discharge pulsating, so that's the attic region. So the eardrum can be subdivided into the pars flaccida, which is the top part of the eardrum, normally between 11 and 1 o'clock, and between 1 o'clock and 11 o'clock you got the pars tensa. Now this region here where I'm working on, the pars flaccida, it can also be called the attic, is prone to getting sucked inwards into the middle ear if you've got negative middle ear pressure. So the air pressure in the middle ear should be equal or thereabouts to the air pressure in the atmosphere, so the ear canal. So when the air pressure is equal either side of the eardrum, that's when your eardrum is most mobile, and that's when you hear the best. So there's a tube in the middle ear called the eustachian tube, which connects to the back of the nose, the nasopharynx. And essentially that's the pressure equalizer in the ear. It allows air to enter or exit to try and equalize the air pressure. So the air pressure in the middle ear is equal to the air pressure in the ear canal. However, if that eustachian tube gets blocked, and it typically gets blocked at the back of the nose in the nasopharynx region, it prevents air from entering the middle ear, so it creates a vacuum effect. And so when you've got a vacuum and negative middle ear pressure, the eardrum gets pulled in. Because the pars flaccida region of the eardrum is less taut than the pars tensa region, so it's more elastic and flexible, it's more prone to getting sucked in due to the vacuum created in the middle ear. And when that region of the eardrum is sucked in, it can be a pocket for where dead skin collects. So the outermost layer of the eardrum is lined with epithelial skin, which is skin cells, which forms the epidermis. And that skin also lines the inner 2/3 of the ear canal. And these skin cells, these epidermis skin cells they're created at the center of the eardrum. So that's the progenitor site. And then once these skin cells are formed, they slowly migrate radially So what I mean by that, if you imagine you've got a puddle or a pond and you drop a stone or pebble right in the middle, you have those ripple effects. So imagine that puddle or pond being the eardrum and those ripples being the dead skin cells. So once they form and are created at the center of the eardrum, they migrate radially outwards, and then they come in contact with the ear canal, and these skin cells slowly migrate from the deepest region of the ear canal towards the entrance, where they eventually shed and should self-expel themselves from the ear. But when you've got this pocket created at the top of the eardrum like this, the skin, as it's radially migrating upwards, it gets trapped in this pocket. And when it gets trapped, it can form into a cyst, a benign cyst, and we call that a cholesteatoma. And then this cyst, it continues to grow, so it's self-growing. And then it can grow and enter the middle ear space. It can grow into the mastoid region, which is to the left. So if we were to go through this patient's eardrum and turn left, you have the mastoid antrum, which is like a little gateway to the mastoid bone. So the mastoid bone is an air-filled bone. It's got honeycomb structure, and it's the bone behind your ear. And in the worst case scenario, it can start to erode all the local structures, so the middle ear bones. It can affect the facial nerve. It can cause mastoiditis, an infection of the mastoid bone. But it can also grow upwards towards the brain, and it can cause a dehiscence or the erosion of the bone, the tigmen tympani bone, which is a thin plate of bone which separates the middle ear and cranial cavity, and potentially lead to meningitis, a brain abscess, and even potential death. And so these benign cysts of dead skin, they are progressively destructive, as I mentioned, and that's because they release proteolytic lysosomal enzyme. And then you obviously then get some bacterial involvement, which also release enzymes, and these enzymes are what destruct all the local structures adjacent to the cholesteatoma. So here there is a bit of a part of the cholesteatoma that's I'm pulling it down and out. So you can see I'm really tugging at this. So part of this cholesteatoma we know is growing upwards. So the ceiling of this ear canal, I'm dragging it from in that region down and out, and you can see there's inflammation there, there's granulation tissue there in the middle ear, which you'll have another clear look at in a moment. So I'm just now spending some time peeling some of this skin from the anterior canal wall. In the anterior recess, the patient did find it slightly uncomfortable on a couple of occasions. You will see that as I'm clearing that. So you can see they've got this large attic region that's eroded, it's perforated now, and the cholesteatoma is still present. Just clearing this way. So this patient has been prescribed topical antibiotics. And they're not your aminoglycosides. Typically for outer infections, there's a group of medications known as aminoglycosides, and they're ototoxic. And what that basically means is if they enter the middle ear, they can sometimes be absorbed by the organ of hearing, the cochlea, via the round window, and they can destroy and kill some of the hair cells within the organ of hearing, which shear side to side and contract in response to sound waves. And when these hair cells shear side to side and contract, they produce an electrical impulse, essentially, which is diverted up towards the brain via the auditory nerve, the hearing nerve, where we process that sound. So they've got a group of medications called ciprofloxacin, which is not known to be ototoxic, so they're using that. So I'm just in that anterior recess. You may have seen the patient slightly flinch. So I'm just going back, peeling as much debris out as possible. So this patient has got a follow-up due with the ENT. And yeah, the primary reason that they don't want to operate is because of the patient's age. As I said, they're turning 95 soon. Yeah, we're just right on the anterior canal wall. This is the isthmus. This is where the ear canal narrows near the eardrum and it widens. So again, you'll see it in a moment, but where that attic retraction is, where the cholesteatoma is, we can see some of the neck of the hammer bone. So the hammer bone itself, which is the visible bone that we see when we examine the ear, the central part of that bone that connects to the middle of the eardrum is called the umbo. Then you've got the stalk travelling upwards, call that the manubrium. Then at the top of the manubrium, you've got a spherical part of the hammer bone, known as the short process or lateral process. And then from there, you have more of the hammer bone extending northwards, which is not always visible. We call that the neck of the hammer bone. And then we've got the head of the hammer bone. And the head of the hammer bone connects to the body of the incus, so the anvil, as it's also known. So all these three bones are connected. So then you've got the body of the anvil, then you've got the short process, you've got the long process, and then the long process of the anvil, or the incus, connects to the stirrup bone, what we call the stapes. So the stapes, you've got the head of the stapes, and then you've got the anterior and posterior crux of the stapes, and then you've got the stapes footplate. And the footplate is what connects to the organ of hearing via a structure called the oval window. So when sounds hit the eardrum, these vibrations are transmitted through the bones, because the bones are all interconnected. They swing backwards and forwards, and that causes the stapes footplate to also go backwards and forwards, and that causes hydraulic pressure changes in the organ of hearing. So the organ of hearing is also full of fluid, and with these hydraulic pressure changes, the fluid in the organ of hearing travels in waves over these hair cells that I mentioned before, causing them to steer side to side and contract, which then produce an electrical signal and sent to the brain. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.